fetal vessels. So Doppler is basically a technique that allows you to look at blood flow of any vessel at a very basic level, tells you whether a tube is a vessel or not. And I use it to differentiate a dilated portovein from a dilated common binder. And in the lower quadrants, I use it to differentiate dilated vertical from dilated vessels. So at a very basic level, you can just turn on Doppler over any tube, vertical tube, and I can give you the information whether it is vessel or not, because in most cases, vessels have blood. It tells you whether the blood flow is towards the probe or away from the probe, allows you to differentiate arterial from venous in many cases, and it gives you velocity in systole and diastole, and gives you information about the characteristics of blood flow and vascular depth. And it allows you to differentiate pulsatile from non-pulsatile, laminar from non-laminar, and very, very importantly, it gives you information about the characteristics of the vascular bed, the proximal vascular bed, the vascular bed at the site of evaluation, and the distal vascular bed. There still seems to be problems with the sound. Can we turn this off, please? Can you turn this off? Yeah, well, I'm trying to optimize this. I'm sorry for trying to turn off this very loud air conditioner behind me. Might be. Okay, so we've done that. Is this better? Is this better? Okay, I hope this is better now. I hope this is better now. Okay, so this will also give you, like I said, this will give you information. This will give you information about what the characteristics of the vascular bed is like. And so, on a very basic level, if we are talking about the vascular bed that follows your site, for example, when we are looking at the umbilical arteries, we are looking at the characteristics of the vascular bed beyond the cell, which is the placenta. And so you need to look at the diastolic phase. If the vascular bed is beyond where you are distal to where you are examining, you need to look at the diastolic phase. So if the vascular bed comes after where you are examining, you need to look at the characteristics of the spectrum afterwards, towards the end of the spectrum. So you are going to look at the vascular phase. So if it's a high resistance vascular phase, your diastolic flow will come down, and eventually your diastolic flow will reduce, and in even worse cases, your diastolic flow will become reversed. And if there is a low vascular resistance distal to where you are examining, then your diastolic flow will increase. Okay. So much so that there are certain spectra that you can recognize. It's like a spotter. You can just look at the spectra and can tell you where this was taken from. So you can look at the internal carotid artery, you can look at the leg vessels, the typical triphasic appearance of the leg vessels, you can look at the swinging waveform from the hepatic veins, you can look at the stable waveform from the portovein and things like that. You have similar characteristic spectra that will allow you to recognize fetal spectra, spectra from fetal vessels. I'm sorry, I'm interacting with people that are giving comments, and I'm trying to follow my slides, so I might appear to be a little distracted occasionally. And so you have these typical spectra from the umbilical artery, you have this typical spectra from the middle cerebral artery, and you have this grossly abnormal spectrum wherever you get it. So the vessels that we are going to be seeing later in this lecture include the uterine artery, the umbilical artery, the MCA, the ductus venosus, the ductus arteriosus, and the aortic. So we're going to be talking about all of these vessels one by one. I'm sure you've had, when you're doing Doppler, you have these two very important questions in your mind. I know I had these questions in my mind. The first question was, should you be doing Doppler in everybody all the time? And the second question was, how early should you start doing Doppler? Is it a good idea to do an umbilical artery Doppler at 20 weeks or not? Well, there was two very interesting papers that came out recently. There was one paper that came out, in fact, earlier this year, it was published in Lancet, so that is a very powerful paper. And they said that if you start doing CPR in all of your third trimester patients at around 35, 36 weeks, you will start to identify fetuses that are at risk for late onset FGR. These fetuses are growing normally, they have normal umbilical artery doctors, they have normal liver, and they are still at risk for FGR. And these fetuses benefit only at about 36, 37 weeks. Okay? So this is a very important paper and has been called the most important paper of the year. Similarly, there was a paper in 2023 published in the British Journal of Gynecology, and they looked at the utility of doing Doppler in the pre-viable state, which means before 25 weeks. And they found that in patients who had Doppler done in the pre-viable state, it added very useful information and characterized those fetuses who were at risk for yeah, and so it has a very high accuracy in diagnosing those fetuses that have related to have a bad outcome. Let's look at the fetal circulation. Now we all know that the placenta is the fetal lung. So let us start tracing the blood flow from the placenta into the fetus. And before that, you please understand that the difference between the circulation of the fetus from postnatal life is that in the fetus you have two parallel systems. Okay, the right ventricle has a parallel flow and the left ventricle has a parallel flow. And there are only three areas where these two flows mix. So you have the ductus venosus, you have the foramen, and you have the ductus arteriosus. In the adult and in postnatal life, you have serial flow. So the blood that goes from point A has to go to point B, has to go to point C, has to go to point. It has to follow the whole circuit before it comes back to point A. But in fetus, that is not the case. You have blood that just goes into one part of the circulation and then the blood that goes into the other part of the circulation. And we're going to see what that means in a little bit. So we have the fetal lungs, which is the placenta, and you have oxygenated blood that goes into the fetus via the umbilical vein. It enters into the fetal umbilicus, goes up, joins the left portal vein, and then it becomes the ductus venosus. Right. So that is a very interesting structure. From the ductus venosus, it goes into the right atrium, but instead of a lot of blood, all of the blood going into the right ventricle, a lot of it short circuits the circulation and goes into the left atrium, left ventricle, and into the aortic root. So you have this oxygenated blood that is coming from the umbilical vein that is going into the inferior vena cava, into the suprahepatic part of the inferior vena cava, which actually is carrying two streams of blood. There is the deoxygenated blood coming from the lower limb and the abdominal viscera, and this is the oxygenated blood that is coming in from the umbilical vein. Okay? And how are these two streams separated? Well, there is difference in velocity, and you have cristavini in the inferior vena cava, little ridges that separate the blood, and of course there is some mixture of blood. And so this oxygenated blood bypasses the right ventricle, goes through the vein into the left atrium, left ventricle, aorta, and this oxygenated blood preferentially goes into the upper limbs and the brain. You have the three aortic branches, you have the brachiocephalic trunk, you have the left common carotid artery, and you have the left subclavian artery. And so this oxygenated blood preferentially supplies the head and the brain. And the deoxygenated blood that we left behind in the right atrium goes up through the pulmonary artery. A bit of it goes into the two lungs because the lungs do need blood to grow. And a lot of it goes via the ductus venosus into this part where you have the three artery branches taking off from the aortic arch, and then you have the deoxygenated blood coming into the aorta. And so the deoxygenated blood goes down into the fetal abdomen and the organs. Okay, so you have a very complex arrangement of how blood flows and oxygenated and deoxygenated blood is divided into the fetal circulation. Okay, and in postnatal life, all of these shunts close and the circulation changes from two parallel sets with occasional mixing into one serial set. And so the deoxygenated blood comes down into the iliac arteries, and you have the umbilical arteries connected to the iliac arteries, and so that is how the circuit is completed going into the fetal placenta. Okay, so what are we examining? Well, there are multiple sites at which you can examine the fetal circulation. We can start by examining the uterine arteries, the maternal uterine arteries, which is the maternal side of the placental circulation, and then you can look at the fetal side of the placental circulation, which is the umbilical arteries. And you can also look at the ductus venosus, the middle cerebral artery. You can try and look at the aortic isthmus. You can look at the ductus arteriosus, and you should be trying to look at the tricuspid valve, especially on a first transcription. Okay, now what is the advantage of having all of these shunts in the fetal life? Well, with two parallel systems, it means that the fetus is more tolerant to a lot of these diseases in utero. Okay, so especially if there is a duct-dependent cardiac malformation, the moment the fetus dies, the ductus arteriosus closes off, and the fetus is in very big trouble. So if we can identify that this is a duct-dependent cardiac malformation, the fetus needs to be treated in a specialized center within the prostaglandins and try to keep the ductus arteriosus open for as long as possible before they can do the appropriate cardiac surgeries and get some kind of sense into the fetal circulation. But having said that, despite these parallel systems, the fetal is not very tolerant to large regurgitated leakage. That is why you need to look at least the tricuspid valve, and if you see a very big tricuspid regurgitation, be sure that this fetus is going to go into high loss. And so these fetuses need to be examined and followed up very closely. This is not something that you should be ignored. So let us hurriedly look at, introduce ourselves to ductus venosus, the foramen ovale, and the ductus arteriosus. The ductus venosus is the connection between the umbilical vein and the anterior vena cava. The umbilical vein ascends behind the anterior abdominal wall of the fetus, goes into the liver, joins the left branch of the portal vein, and then it becomes a narrow trumpet-shaped vessel, which is the ductus venosus. How many of you have seen the ductus venosus? How many? One? Two? Of course. Three? Yes, sure. Yeah, well, quite a few of you have seen the ductus venosus. How many of you try to see the ductus venosus in a significant number of your cases? All right. Okay, good. Excellent. Excellent. All first benches. So ductus venosus is a very, very important vessel. You should know how to identify it. You should be familiar with the Doppler characteristics. It is not an easy vessel. The fetus is usually not cooperative. The fetus needs to be either facing you or facing backwards. You can look at the ductus venosus in either the longitudinal section or the cross section. You should be able to identify the ductus venosus. Please know that there are a lot of vessels there in the region of the ductus venosus. You have the umbilical vein, you have the hepatic veins, you have the portal veins. So a millimeter here or a millimeter there will give you the wrong vessel. So you have to look and be sure that you're actually examining the ductus venosus and not anything else. Okay, the thing about ductus venosus is that in that area, the ductus venosus has the most rapid blood flow. Right? Which means that when you turn on Doppler, this is the area that has elizing. And so you can turn down the Doppler gain and you can increase the Doppler threshold, and you still have a vessel with elizing. And that is where you have the ductus venosus, and that is where you need to put your Doppler gate. And your Doppler gate needs to be very small. It needs to be 5 millimeters, 0.5 millimeters, or 1 millimeter at most. So don't use your standard Doppler gain, which is 2 or 3 millimeters, because you're definitely going to be picking up other vessels also. So you need to narrow your Doppler gain, your Doppler window. Be sure you're in the ductus venosus, and then turn your spectrum on. The ductus venosus has a typical triphasic appearance. You have an upstroke in systole, an upstroke in diastole, and then you have a downstroke in aortic, in atrial contractions. You have S wave, E wave, and A wave. And you're interested in if the A wave is not negative or not zero, then you're interested in the pulsatility index. If the A wave is 0 or negative, then you can eyeball it and give an impression of how the ductus venosus flow is. So this is the ductus venosus flow. You have 2 upstrokes and 1 downstroke. So this is characteristic of ductus venosus flow. This is also characteristic of pulmonary venous flow. So if you're looking at the pulmonary vein, you will find that the characteristics of the pulmonary veins are very similar to the characteristics of the ductus venosus. Okay. Let's look at the foramen ovale. All of you know that the foramen ovale is present in the interatrial septum. This is actually an opening between the 2 interatrial septa, and blood passes normally through the foramen ovale from the right atrium to the left atrium. And you can actually see the foramen veil on grayscale, and you can see the foramen veil on video. And you can see the little flap of the foramen veil, in the left atrium. And the rate of the flutter of the foramen veil is usually twice the cardiac. Okay, and you can turn on Doppler and you can look at the flow. It's such a this thing. Okay, so you can see the blood flow go in from the right atrium to the left atrium. Okay, the ductus arteriosus. Right? Sounds scary. Ductus arteriosus sounds scary, but actually this is a very, very easy vessel to see. It's very easy to see in a transverse section. It is kind of difficult to see in a longitudinal section when we are actually trying to see the ductus arch. So the ductus arteriosus is the little vessel that is the continuation of the pulmonary artery. After the two branches, the right and left pulmonary arteries have been given up by the main pulmonary artery, the ductus venosus starts, it's a short vessel, and this connects to the aortic arch. And so you can see this in your typical three-vessel trachea view. You're seeing the ductus arteriosus and you're looking at the aortic arch. So if you're used to seeing the three-vessel trachea view, you're seeing the ductus venosus in all of these cases. So it sounds scary, but it isn't, and it is fairly easy to identify, especially in the short axis. The uterine artery. This is a very, very important vessel that we should be seeing more often. The anatomy of the uterine arteries, actually there are two uterine arteries that supply the uterus. The ovarian artery is anastomosed with the uterine artery to also supply the uterus. The uterine arteries branch off and eventually become the spiral arteries. These spiral arteries are physiologically important in the non-pregnant woman because it is the spasm of the spiral arteries that causes ischemic necrosis of the endometrium that leads to menstruation. But in the pregnant woman, the spiral arteries are very, very important because these are the final and the most important vessels that determine the placental flow. What happens is that there are two waves of trophoblasts that invade into the spiral arteries and they destroy the muscle layer of the spiral arteries and converts them from like an arterial flow into a venous flow with very low resistance. And that basically is what ensures an adequate supply to the fetus. Because you have this lot of blood that is going into the placenta, and how does this blood reach there? It is because the spiral arteries have converted into very low resistance dilated vessels that allow a lot of blood to go into the placenta. But why are we interested in uterine artery Doppler? Well, because if you have inadequate trophoblastic invasion of the spiral arteries, you have a placenta that is not, if you have a starved placenta, and the starved placenta reacts by sending off a lot of biomarkers into the biologically active markers into the maternal blood, and that creates a lot of problems, muscles, and creates problems like gestational hypertension, preeclampsia, and eclampsia. And one of the things that you can do to identify patients at risk is to look at the Doppler of the uterine arteries. So you should be doing a uterine artery Doppler in all of your first trimester scans. Okay? I should be doing your uterine artery Doppler in many of your second trimester scans. And you should be doing uterine artery Dopplers in a few of your third trimester scans. And hopefully we'll be able to identify that population where you need to do a uterine artery Doppler. Now this is very, very important because hypertensive disorders of pregnancy are a major cause of maternal death. The incidence of hypertensive disorders of pregnancy is rising. As we have more nutrition, we have more diabetes, we have more obesity, and so these problems are rising. So it is very, very important to be able to identify them. It is also very important because we can actually do something about these patients who are at risk of hypertensive disorders of pregnancy. The final solution is to deliver the baby, that will cure the patients in most cases. But you can actually start giving the baby aspirin very early on, after about 13 to 14 weeks, certainly before 16 weeks, and it works almost magically in lowering and preventing eclampsia and pre-eclampsia. And so, recommendations are to start aspirin very early on. And how are you going to identify those patients in whom you're going to start aspirin? We're going to talk about that, but I guess uterine artery Doppler is one of those things. And if you look at the efficacy of aspirin, it is really very substantial and very magical and useful. So can we just rely on uterine arteries to identify our patients? Can we uterine artery to identify our patients who are at risk? Uterine artery Doppler is one of the components of your analysis, but it is not the only component, and it has to be analyzed in context with other patient characteristics. So by looking at the maternal demography, the BMI, presence of diabetes, history of a previous preeclampsia, if you just doing that, you have about less than 50% sensitivity for identifying patients who are at risk. If you add mean arterial blood pressure, and I'm sure nobody knows how to take a mean arterial pressure, we're going to talk about that. You increase it, you add about 10% of sensitivity. If you add uterine artery Doppler, you have about more than 80% sensitivity in diagnosing your patients. And if you add placental growth factors, then you have a very, very high sensitivity of about 90%. Mean arterial pressure is actually the diastolic pressure plus 1/3 pulse pressure. And pulse pressure is the difference between the systolic pressure and the diastolic pressure. So mean arterial pressure doesn't mean systolic plus diastolic divided by 2. Mean arterial pressure here means diastolic pressure plus 1/3 pulse pressure. Okay, so I think this is a little trivia that might be useful to some of you. So how to acquire uterine artery Doppler? Well, you can do it in trans-vaginal view on a TBA, or you can do it on trans-abdominal view. Both are possible, but you need to practice, you need to be able to identify. And one of the things, a lot of us are obsessed with notching. Notching hai to kharab hai, notching nahi hai to theek hai. So let us stop worrying about the notching, because notching is something that is very, very common. At about 14 weeks, where you are doing most of your first trimester scans, you will have notching in about 50% of your uterine arteries. At the time of the second trimester scan, you still have notching in about 20% of the cases. If at the late second trimester, you will still have notching in 10%. So if you just rely only on notching, you're likely to overcall a lot of your patients. What you should do is you should learn to use charts, and you should learn to use the distribution of PIs in that particular age. And these charts are freely available at the FMF site. So you just save your FMF site on your computer and start using this to check your PIs and the percentile where the PI lies of the uterine artery, the umbilical artery, the MCA, and it will also allow you to diagnose CPR maybe third times. So we need to do the uterine artery Doppler in everybody in the first trimester, quite a few in the second trimester, certainly in high-risk cases, and a few in the third trimester. And so please understand, like I said, I'm re-emphasizing this, that there are no universal threshold for uterine artery Dopplers. And you have to have a calculation, individualized calculation, like you do for aneuploidy. Aneuploidy is a risk calculate, but when you're doing a risk for aneuploidy, you're factoring the maternal age, okay, and then you're factoring the likelihood ratio of the different risk factors that you've identified, and then you're using all of those to identify the risk. Okay, so it is a same procedure that we use to identify the value of whatever you have determined in the uterine artery in that particular patient. And it's not difficult. Again, you should go to the Fetal Medicine Foundation and you can go to this page that will allow you to input a lot of maternal characteristics, also tells you the maternal age, it tells you the crown rump length, and at the end, at the bottom of the page, it gives you a risk of age levels. Okay? So you should be doing that. And so this is a way of doing uterine artery Doppler when you're looking at the paracervical region. Okay, so you can see this. You can start in the middle. Without sliding your probe, you simply tilt your probe, turn on your Doppler, and you have this very big vessel going inside the uterus. And that is the uterine artery. And you can use your spectrum there. The uterine artery is usually more than 60 centimeters. You need to get both uterine arteries. You need to get the PIs. You need the average of those PIs, and then read it off from the charts that we have. Go to the FMF. A close friend, umbilical artery. Everybody does that. We're all familiar, so we just rush through this. You start getting information from the umbilical artery the moment you turn on Doppler. So if you're just looking at color Doppler, it can tell you about whether you have the normal 3-vessel configuration or you have a 2-vessel cord. It can tell you if there's a cord around the neck. I don't know how useful that is. Again, gynecologists are very, very interested in cords around the neck at 28 weeks, 29, 30 weeks. Really, it shouldn't even be reported at that time. Can tell you if this is a single knot, a single coil, a double coil. If you're very, very lucky, you might even be able to pick up a knot once or twice in your lifetime. And if it can help you to differentiate between an fallacy, gastroschisis, and bladder exoscopy, and we haven't even started looking at the spectrum. But now we turn on the spectrum, and what are we looking at? Basically, we are looking at central vascular irrigation. And the umbilical artery Doppler should always have flow during the diastole. And the flow should improve as the pregnancy advances. You can use SD ratios, but it is preferable to use the PI in most cases. And please stop eyeballing. Unless it is grossly abnormal, don't just have a subjective evaluation of your umbilical artery Doppler. Okay, it needs to be correlated with the gestational age, and then you need to see exactly where the value falls. The umbilical artery Doppler, you must remember that you can have an abnormal umbilical artery Doppler in patients who do not have FGR. They have normal, they have normal growth, they have some other problem, then you have a normal umbilical artery Doppler. And you can have a normal umbilical artery Doppler in many cases of FGR. Especially in late onset FGR, the umbilical artery Doppler continues to be normal. So just relying on umbilical artery Doppler, you have to be very, it's a very treacherous vessel to analyze. So just relying on umbilical artery Doppler is likely to lead you into a bit of trouble. We get very worried with absent and diastolic flow, which is right to be worried, but maybe we are overreacting to absent and diastolic flow. We are also overreacting perhaps to reverse and diastolic flow, and we are going to talk about that later in this lecture, and we are going to have a whole dedicated lecture on how to interpret your documents. So this is a case where you have an impaired, an abnormal, very low end diastolic flow in the umbilical artery in a patient that had a normal liquor that was growing appropriately, but the patient had abnormal features, epidemic kidneys, a bit of ascites, asymmetric lateral ventricular dilatation. So definitely this patient has a problem which is simply not FGR. There's something more than that happening in this. You need to try and get a free floating loop of your umbilical artery, because the Doppler spectra are different at the placental edge from the fetal edge. The PI is lower at the placental edge and higher at the fetal edge. And this is the same patient if you have a PI of 1.56 in this vessel and a PI of 1.14 in this vessel. So be sure that you are identifying a middle part of your umbilical arteries. So if you want, you can take a picture of this slide. It's how to actually get a good quality umbilical artery Doppler. I think a lot of us are doing it very casually, because it's so easy to see. We just see whatever we are seeing, whatever zoom we have. We just put on the Doppler. We don't care about the angles. People said that you shouldn't be caring about angles if you're taking PIs, but the current understanding is that you should take angles into consideration and try and get a low angle, as low an angle as possible in all fetal vessels, even if it's umbilical artery, and always try to get an angle that is below 30 degrees. You should have sampled multiple waveforms. I know I use one waveform, but sometimes I use three, but you should try and use more than one waveforms. Don't eyeball in all of your cases. Sometimes the subjective appearance of an umbilical artery Doppler can be deceptive. So you would say, okay, this is normal and this is also normal. This is definitely abnormal, okay? So this is normal and your PI is at the 50. Good. This looks normal, but your PI is above the 95th centile, which is definitely not normal. And you should be very worried about this case. Okay? You should be very worried about this case. And so, if there is anything off with the fetus, go into the detailed Doppler mode, get your images. If your machine gives you the PI automatically, well and good. If it doesn't, take the hard copy, go to your reporting room, turn on your FMF website, input your PIs at that particular age, and get where the PI is lying. And I'm sure you will be doing your patients and your referring physicians huge service. Okay. An early FGR, reverse end diastolic flow, has a window of about 1 week before it deteriorates. In late FGR, please understand that umbilical artery Doppler remains normal, but the fetus is still at risk for stillbirth. And you have a very high incidence of stillbirth in late FGRs. And it is a very sneaky problem, and unless you are actively looking for late FGRs, you are probably going to miss a lot of these stages. Let's look at the aortic isthmus. How many of you know that there is something called an aortic isthmus? Okay, so this we will be finding it useful. Okay, we have the ductus arteriosus joining the aorta. You have the aortic arch with the three vessels, and you have this tiny segment of the aortic arch, which is the aortic isthmus. And this is the border between the left ventricular flow and the right ventricular flow. Alright? And if you get used to looking at this, it gives you a lot of information about the cardiac status, the cardiac failure, and aortic isthmus is also abnormal in a lot of physiological problems. It is easier to identify in the three vessel trachea view. It's more difficult to identify in the arch view, or maybe it is more difficult to identify for me, but it is definitely easy to identify in the three vessel trachea view. Okay, it's a marker of cardiac dysfunction. It's a predictor of poor, adverse, poor outcome. It is a predictor of anomalous neurodevelopment. It's an independent predictor of CNS lesions, and you have an ultrasound sensitivity of about 70% if there is reverse flow, or we can see it is less than the fifth septile. Normal flow is antigrade throughout the cycle. So if you have stop flow, no flow, or reverse flow, you are either looking at placental insufficiency, you're looking at hypoxemic right ventricular dysfunction, you're looking at brain split with increased flow through the three branches of the aortic arch. And so, like I said, you can identify the aortic isthmus in the three vessel trachea view. It's just at the end, or you can identify it in a longitudinal. So you have a very sharp upslope, you have a very sharp downslope. This is followed by an incised dura, small tiny upslope, and you know that you're looking at the aortic isthmus. The advantage of aortic isthmus is that this is one of the first vessels that start showing an abnormal flow in FGR. So it's very early, so it puts you on guard. Okay? So this yellow line is the aortic isthmus, and this really starts to rise significantly, and it is a sensitive vessel. But given the technical difficulty of identifying the aortic isthmus and getting a proper spectrum for it, it's not used very often, and a lot of people substitute the ductus venosus flow for aortic isthmus, and we need to be talking about that. Building cerebral artery, everybody does building cerebral artery flow, there is no big, but you need to have a good quality middle cerebral artery flow. It reflects the cerebral circulation. You use it in two situations. You use it when you are suspecting fetal anemia and you look at the peak systolic velocity. In fact, this is the only non-invasive test that you have for diagnosing fetal anemia. And you use it in cases of cerebral redistribution and a high diastolic flow in the middle cerebral artery reflects fetal adaptation to hypoxemia with cerebral artery dilation. Again, you need to use your TI charts. How you see it, you identify the circle of Willis, you go at the base of the skull, you turn on your Doppler, and you look at the circle of Willis, and this is the vessel that is coming straight towards the probe. You have some conditions that mean some quality assurance, some quality issues with middle cerebral artery Doppler, and you need to take care of these so that you are sure that you're getting a good quality. By the way, all of these are present on the GLOM website, glowf.com. That is the Global Library of Women's Medicine. It's a free website. and if you go there to search for fetal Doppler, you'll get a very nice paper there that tells you exactly how to acquire good quality Doppler spectra from the fetus. Okay, when you're doing MCA Doppler, please remember that the fetal circulation is sensitive to pressure. So if you press it very hard, your diastolic flow might artificially go down. Okay? So if you are seeing that you have zero diastolic flow in your MCA, just release the pressure and the diastolic pressure is likely to go. So this is a practical tip. You can use it for fetal anemia. I would urge you to download this chart. It is available on the internet. And you have conditions that predispose the fetus to anemia, like you have RH isoimmunization, you have some atypical antigens, you have infections, and alloimmunization are the two most common causes of fetal anemia. You have this in monochorionic diamniotic twins are always at risk of fetal anemia. It's either a TTS or twin anemia polycythemia sequence, so PAPS and PDTS, and just having monochorionic twinning puts your fetus at risk, and you should be doing this. Okay, what is this thing about MC? Now, this is a very interesting thing about fetal physiology. What happens is that as the fetus grows older, the fetus matures, the requirement of nutrition stabilizes, but the requirement for oxygenation goes up. Okay? So, if you're going to find an abnormality, you're going to find an abnormality in the region of the red graph. The fetus is hungry for oxygen, and if there is anything wrong with oxygenation, the fetus is going to react, and it is going to give you evidence that something is wrong. And that is why MCA Dopplers is important in late FGR, because this is the time when the fetus is hungrier for oxygen than for glucose. Okay, and so that is that the fetus doesn't stop growing. The fetus is still producing urine. You still have normal or nearly normal AFI, but the fetus is responding to oxygen deprivation by adapting to it, by increasing your cerebral flow, and that you can pick up very easily by doing an MCA Doppler and deriving a CPR. Okay, let's go back to ductal stenosis. We already know how it is formed. It is the continuation of the umbilical vein after it has joined the left portal vein into the inferior vena cava. So this is the connecting vessel between the umbilical vein and the inferior vena cava. It is a hidden treasure. You should be looking at it more often. You should certainly be looking at it in your first trimester scans, because a negative A wave, some people say an absent A wave, identifies people who are at risk for aneuploidy, cardiac defects, and if nothing of that, just poor pregnancy outcomes. So you need to be more careful if you find fetuses with an absent or negative ductal stenosis. In the second and third trimester, in the context of FDR, if you find an